Well, in this week's cardiology news, we have information from another cohort on gender differences in how patients present with an acute coronary syndrome. Also, a nice analysis of a bleeding risk score in patients who are anticoagulated for atrial fibrillation as compared with the CHADS and CHADS-VASc score. And finally, a meta-analysis of the use of dual antiplatelet therapy early on in TIA or stroke patients. So to begin with, we have an analysis of gender differences from a cohort of a little over 1,000 patients, 30% of whom were women, in what the presenting symptoms were when patients came in with an acute coronary syndrome. And the focus was on the presence or absence of chest pain, where it was seen that fewer women had chest pain as part of their presenting illness, although the absolute rates were both pretty high, about 80 to 85%. And so, seen both ways, one can say that chest pain is still the most common presenting illness and syndrome with an acute coronary syndrome, but that happens a little bit less frequently in women, and so one has to be vigilant for other symptoms such as shortness of breath. Interestingly, in this cohort, there wasn't a difference in how many evolved a positive troponin. In prior cohorts within studies, women have been seen to have less often troponin elevations, more often BNP and CRP. A second study I wanted to highlight this week is one that looked at trying to predict not just the risk of stroke in patients with atrial fibrillation, as we do with the CHADS-2 risk score and also the CHADS-VASc risk score, but to also incorporate in the assessment of bleeding. And the so-called HAS-BLED risk score has been developed to focus on major bleeding. And this was looked at in a series of 1,370 patients in an outpatient clinic that were followed for many years. They had a rate of major bleeding of about 3% per year, including 0.8% per year of intracranial hemorrhage in this broad unselected population. And not getting into statistics, they did find that the HAS-BLED score was the best way to predict the risk of major hemorrhage as opposed to the CHADS or CHADS-VASc score. And so I think this encourages us to do risk stratification not only for efficacy and stroke prevention, but also on the safety side, predicting the risk of bleeding. Then how to adapt, we have multiple different choices of agents now, and that could inform a way to potentially optimize therapy. And the number one study this week, I think, is a meta-analysis that tries to build on the results from the CHANCE study that looked in patients who were presenting with a TIA or non-thromboembolic stroke, and looked at use of dual antiplatelet therapy, that is aspirin and clopidogrel, as compared with just aspirin alone. And as you may recall, in the large CHANCE study, about 9,000 patients done exclusively in China, there was a significant reduction in the risk of stroke when given for a 3-month period, after which aspirin alone was continued. This meta-analysis added in 14 studies total, so an additional 13, of which 7 were double-blind, although much smaller numbers of patients, but the findings were very consistent. These were done around the world, not just exclusively in China. And so while not definitive, I think looking at the world's experience, the use of early dual antiplatelet therapy in acute TIA or stroke appears to be beneficial. There are ongoing studies, however, around the world to try and do that in a large prospective study in a multinational population. So for this week's Cardiology News, I'm Chris Cannon.